So, hi everyone. My name is Abhinav, and I will be presenting a paper that I published in the European Heart Journal, Cardiovascular Pharmacotherapy. It's on the role of ACE inhibitors um, in COVID-19 patients with hypertension, and this was published in the year 2021. Right. So, as a background, let me start off by discussing the mechanism of ACE inhibitors or mechanism of SARS-CoV-2, how it sort of enters the body and causes infection. So we know, like from previous studies, that um, SARS-CoV-2 binds to ACE inhibitors, but it may actually upregulate the ACE2 expression as a result of that. And at the beginning of the pandemic, there were some concerns which were centered around the safety of its use in COVID-19 patients. And the medical societies, though, recommended its continued use in patients who have hypertension on other indications for the use of ACE inhibitors due to lack of evidence suggesting any safety concerns. So the objective of this study was to essentially evaluate the clinical severity and mortality outcomes in COVID-19 patients who were on ACE inhibitors or ARBs. And so with that objective, we conducted a systematic review and meta-analysis of the available studies. We included several databases in our search, such as PubMed, Google Scholar, Embase, Medrix, Pyrix, etc. And the inclusion was basically of studies that were done in humans, were in English, and published up until May 1st of 2020. There were 16 studies included, and meta-analysis was performed on 4 of them for the severity of outcomes, and which is again the morbidity associated with the use of these drugs in COVID-19. And then there were 6 studies which we could include for mortality outcomes. So in terms of findings, we saw that there was a mixed result across the different studies that were included in this analysis. For severity, again, there were 4 studies that were pooled together, and the odds ratio of the severe outcomes was 0.81, with a confidence interval of 0.41 to 1.58, which means it was statistically insignificant in terms of its association with the use of ACE inhibitors. So again, no significant association of severe disease with the use of ACE inhibitors in COVID-19. And then the funnel plot showed a moderate amount of publication bias, but it was sort of acceptable. And this diagram here actually shows the different studies that were included. If you can see my arrow here. So these are the 4 different studies included. Again, variable results across the studies in terms of odds ratio. One of them had a higher odds ratio of 1. And the other ones had, or actually another one had more than 1, but the other ones had less than 1. But all of them were statistically insignificant, and the pooled analysis kind of showed the same thing. Here on the right, you can see the forest plot showing that the odds ratio crossed 1 and therefore was statistically insignificant. Again, funnel plot shows that many studies were sort of in the funnel, but there were some outside, and there was a moderate amount of publication bias, but acceptable. In terms of mortality outcomes, again, the outcomes were conflicting. Some studies showed that there was lower mortality associated with the use of ACE inhibitors or ARBs in COVID-19, whereas others showed a higher or equivalent mortality. The pooled analysis, which was done on 6 studies, showed that the odds ratio was 0.86, again crossing 1 or including 1 in the range, 95% confidence interval range, and therefore there was no statistically significant association of their use in COVID-19 with mortality outcomes. This is a forest plot showing, again, all the studies that were included in the mortality outcomes data. Some of them showed favorable outcomes, the others showed unfavorable outcomes, as you can see in the forest plot here. These are some of the unfavorable outcomes. And then these other studies showed favorable outcomes with COVID-19 or ACE inhibitor used in COVID-19 patients. Overall, though, again, the pooled analysis, the odds ratio, the 95%, the upper and the lower limits included one, the range from 0.846 to 1.2 here, and the fixed analysis and the random plot analysis showed a range of 0.53 to 1.4, and the p-value was greater than 0.05, so not significant. The funnel plot for the mortality was kind of similar to the one we saw for severity, where you had some studies sort of falling out of the funnel, but still acceptable in terms of its publication bias. All right, so based on that analysis, there was no clear evidence at the time to discontinue the use of ACE inhibitors and ARBs in disease states such as hypertension, MI, chronic kidney disease, etc. And so that was a significant change in practice that people were proposing, but this suggested that people can continue, and the medical society sort of recommended the same based on our analysis and other studies that were ongoing at the time. You sort of had to balance between the potential protective versus harmful mechanisms, but if someone is or has an indication for its use, then you continue to use those. There is a caveat, though. Some people may have ACE2 polymorphisms, so there was the option to check for that, at least on a research basis, to see if individuals with those certain polymorphisms may have higher risk of COVID-19 or mortality or severity outcomes with use of these drugs in COVID-19. And again, at the time, there was a need for randomized controlled trials. There were certain trials that were ongoing at the time, which have since shown that the use of these drugs was not associated with severe outcomes or increased mortality in COVID-19 patients. So to conclude, again, these patients or COVID-19 patients should not be, or their therapy with ACE inhibitors or ARV should not be held back. It did reinforce the recommendations made by the major medical societies. The future studies, which have been done now and are still ongoing, some of them, but they explored the various genetic factors such as ACE polymorphism, long-term outcomes, and all of them pretty much showed consistently across the board that these drugs can be safely given to these patients. Okay, so I had like several key references. I didn't list them out there, and I have no conflicts of interest. So thank you.